Hi guys, welcome back. So there were a lot of technical issues from the YouTube side, and that's why we could not live stream the lessons at the earlier scheduled time. Nonetheless, we're back and we will be discussing the important questions from the cardiology. Now also the technical issues are not completely resolved and I may not be able to see all of your comments in real time. So if I miss out or addressing any of your queries, don't hesitate to ping me on the Instagram and I will definitely come back with a solution for your problem through a voice note or a text note, whatever feasible whenever I get time. Okay, so the question that we will be discussing now is the heart failure. Heart failure, time and again across universities, had been one of the important and repeatedly asked questions, like real for real, right? So the question on heart failure may go like this: define heart failure, discuss classification, pathophysiology, diagnosis, and management. What particularly teachers are interested in looking at when they are assessing the answers is mainly whether you write the classification properly, whether you have an idea of pathophysiology. Management wise, as long as you're able to list the pharmacological intervention and non-pharmacological intervention, that's more than enough. And as I've told you, for all long questions, I would expect you to write a brief 1 or 2 sentence introduction. And if the question itself is asking you to define a condition, then you don't need to write the introduction. You can directly start with the definition. Okay, so what is heart failure? The conceptual definition of heart failure is heart has to work. Mainly, we are concentrating on ventricles, and ventricle is supposed to contract and eject the blood, right? And to be able to eject the blood, first it has to receive the blood. So yesterday in the class, I have told you that we have something called as isovolumetric relaxation in diastole that enables the ventricles to lower its pressure below atria and then it can receive the blood. So receiving the blood by ventricles is an important function. Similarly, ejection of blood by ventricle is also important function. Both of them are functions of heart. If any one of them is not happening properly, I would call it as heart failure, right? So how many of you agree with my conceptual definition of heart failure? Crazy loser, we would be covering the important topics. So the definition wise, I would define as impaired because as I just told you, heart has two functions: receiving the blood, that is filling of the ventricles, and ejection. So one of them impaired is failure of heart. So impaired ventricular filling, or ejection, or both, then we will call it as heart failure. Okay, now this is a conceptual definition. What is the technical definition? The technical definition is patients with signs and symptoms of heart failure. Later I will discuss the signs and symptoms of heart failure. For now, just understand anyone with signs and symptoms of heart failure plus a biomarker suggestive that these symptoms are because of heart failure. See, one of the symptom of heart failure is shortness of breath. There are n number of causes for shortness of breath, right? Can anybody list the important causes for shortness of breath apart from heart failure? Like pneumonia, then pleural effusion, pneumothorax, pulmonary embolism, severe anemia, high altitude, all of them, right? So when I can link the patient's shortness of breath to the failure of the heart with the help of a biomarker, then you can say, hi, this person has got heart failure. And that biomarker is N-terminal proBNP. So if there are signs and symptoms of heart failure with elevated biomarker of heart failure, that is equal to heart failure. Then you have heart failure. This is a technical definition. Okay, now that we know the definition of heart failure, let us look at its classification. So there are various ways of classifying heart failure. The first classification that I'm putting out is mainly looking at the heart as right heart and left heart. So we can classify heart failure as right heart failure and left heart failure. Now, traditionally speaking, most of the cases of heart failure that we're going to encounter in our clinical practice are going to be left heart failure. Right heart failure is much less common. So that's why if any teacher during the ward rounds randomly discuss about heart failure, he is mostly pointing towards left heart failure. Okay. But now that we're writing a prof answer, we will classify it as right heart failure and left heart failure. So when I say right heart failure, the right ventricle has either impaired filling, it's not able to fill the blood, or it's not able to eject the blood. When I say left heart failure, I'm referring to left ventricle not able to fill the blood or not able to eject the blood. So left heart failure and right heart failure. Now, in terms of the clinical features, or you want me to mention some causes? Okay. The causes for right heart failure and causes for left heart failure. The causes for right heart failure, most common cause of right heart failure is left heart failure. That's what we have been discussing from yesterday as well, right? So when we talk about heart per se, anything that affects the left side of the heart eventually will come to right. That's what we learned yesterday, right? Whether we had aortic stenosis, mitral stenosis, aortic regurgitation, mitral regurgitation, and left heart failure. All of them have one common feature, that is increase in the left atrial pressure. And when left atrial pressure increases, the pulmonary vein pressure increases. And if pulmonary vein pressure increases, eventually pulmonary capillary pressure increases. Then pulmonary artery pressure has to increase. And once pulmonary artery pressure increases, there are some compensatory changes happening in the right side of the heart, right? Can anybody tell me what are the compensatory changes happening in the right side of the heart if pulmonary artery pressure is high? Well, pulmonary artery generally offers some degree of resistance for the ejection of blood by right ventricle. That's what we call as, what do we call it as? The resistance given by the blood vessel for ejection of blood into it by the ventricles. On the left side, when left ventricle tried to eject into aorta gave a resistance. We called it as afterload of left ventricle. So similarly, right ventricle will also face afterload, which is the resistance given by pulmonary artery. If pulmonary artery pressure is already high, it is going to give more resistance. So afterload increases. And remember yesterday, what did I tell you? Whenever there is increase in afterload and ventricles do more work to overcome that, they do develop hypertrophy. Increased afterload leads to what kind of hypertrophy? Concentric hypertrophy, right? And I don't want you to get confused. Where do you get concentric and where do you get eccentric? If there is increase in the preload, you get eccentric hypertrophy. But if there is increase in the afterload, you get concentric. How do I remember it? Remember ACPE. P means pulmonary embolism. AC means air conditioner. Right now, most of you may be sitting in air conditioned environment. So when afterload increased, you get concentric. When preload increased, you get eccentric. ACPE. That's what I want you to remember. So now, here in this scenario, because of increase in the pulmonary artery pressure, right ventricular afterload increased, right ventricle developed concentric hypertrophy. And once right ventricle developed concentric hypertrophy, what happened to its volume? Ventricular volume decreased. If volume decreased, do you think I can fill the sufficient quantity of blood into the right ventricle? Smaller, see, earlier I used to drink, I mean, I don't drink, but just imagine that earlier I used to drink in liters glasses. Now I have tiny cups because doctor said drinking too much is not good. So now can I fill 1 liter of alcohol, madira into my tiny cup? No, I can only fill 150 ml because the cup size itself is decreased. If you give me a 1 liter bottle, I'll pour 1 liter and drink, right? Simple. Ventricular size decreased. So the amount of blood I can fill decreases. So what impaired now? Filling got impaired. And yesterday we learned that if I fill less, I will be able to eject less only, because if I'm getting less, I can eject less only. If I'm not getting sufficient, how can I eject more than what I'm getting? Not possible. Simple. So impairment of right ventricular filling happened. And what did we define heart failure as? Impaired ventricular filling or ejection. So the problem that started in the left eventually resulted in impaired right ventricular filling. So right heart failed. Got it? So the most common cause for right heart failure is left heart failure. Most common cause for overall right heart disease is left heart disease. When left gets affected, somehow the problem reaches the right. So left heart failure is the most common cause. Apart from that, we have cor pulmonale. What is cor pulmonale? Respiratory disorders causing right heart failure. Yesterday we discussed about it. We have discussed about it in COPD as well. Especially chronic bronchitis patients, whom we call as blue bloaters, are prone to develop cor pulmonale. Why? Because in chronic bronchitis, alveolar hypoventilation is there, hypoxia is there. Because of the hypoxia, pulmonary capillaries constrict, and once the pulmonary capillaries constrict, once these capillaries constrict, behind that the pressure starts building up, pulmonary hypertension. And once you have pulmonary hypertension, afterload of the right ventricle increased, And once the right ventricular afterload increased, I have concentric LVH. Once I have concentric, RVH. Once I have concentric RVH, I have less space to fill. Filling of the right ventricle reduced, and impaired filling is heart failure, right? So cor pulmonale is second cause. Okay, apart from that, what other causes I can list for right heart failure? Pulmonary arterial hypertension. Then right-sided valvular heart diseases. Valvular heart diseases on the right side, like pulmonic stenosis, pulmonic regurgitation, tricuspid regurgitation. They can also cause right heart failure. So these are all causes for right heart failure. Now, what are the causes for left heart failure? Of course, I can't say the most common cause for left heart failure is right heart failure. The problem of right does not reach the left. Only the problem of left reaches the right. So overall, the most common cause for the left heart failure is hypertension. Now you may be wondering, how, sir? How hypertension becomes a cause for heart failure? Simple. If you have hypertension, your pressure inside the aorta and its branches is high. Just like how I had pulmonary hypertension. Pulmonary hypertension resulted in increased afterload of the right ventricle. Systemic hypertension increases the afterload of left ventricle. And when afterload is increased, you develop concentric LVH. The most common cause for left ventricular hypertrophy is hypertension. Now that I have developed the concentric LVH, I have less space available for ventricular filling. So during diastole, I can't fill sufficient quantity of blood into the ventricle. And because of that, the amount of blood ejected or the stroke volume comes down. Now again, I can call this as heart failure, impairment in filling. Simple. That's most common cause. The second most common cause is ischemic heart disease. Now you may be wondering why ischemic heart disease causes heart failure. Now just look at this heart. This ventricle is a muscle, right? It is able to contract because it is muscle, and for it to contract, it needs blood supply, which comes from the coronary artery. Now if coronary arteries get blocked, this ventricular myocardium is not going to get sufficient blood supply. If it does not get sufficient blood supply, can it contract? No, its contraction will get affected. Just to give you an example, let us say someone developed this lateral wall MI. So this part of the ventricle is what we call as lateral wall, right? So here he has developed this lateral wall MI. This part of the myocardium is dead, infarcted. It can't contract. So only interventricular septum and the right side of the heart is contracting. This part, lateral wall, is not contracting. So do you think the amount of force that this ventricle can generate to eject the blood will be same as before? Of course not. Like, think of this. This is ventricle. It is the interventricular septum. This is lateral wall. Both contract to eject the blood. Now, only interventricular septum is contracting. The lateral wall doesn't. So then how will I eject the blood? Right? The force of contraction comes down. The amount of blood I would be able to eject will also come down. So stroke volume is less. Now what got affected here? Ejection got affected. So this is also heart failure. Impaired filling or impaired ejection is heart failure. So now I have ischemic heart disease also as a cause for heart failure, right? Apart from that, what if the left ventricular muscle mass starts thinning out or getting atrophied? That is also heart failure, because then ventricle cannot contract and generate sufficient force. So that can happen in patients with dilated cardiomyopathy. Okay. What if I develop hypertrophy of the left ventricle, just like how I got it in hypertension, but without hypertension? Yes, that can happen in hypertrophic cardiomyopathy. So similarly, the restrictive cardiomyopathy causes mainly right-sided heart failure. So I want you to remember this. R for R. Restrictive cardiomyopathy causes mainly right-sided heart failure. Dilated and hypertrophic cardiomyopathy mainly cause left-sided heart failure. Dilated cardiomyopathy, the left ventricle is thinned out, muscle mass is less, that's why ventricle is dilated. So its force of contraction comes down, ejection get affected. In hypertrophic cardiomyopathy, the force of contraction is good because muscle is hypertrophic. But because it is concentric type of hypertrophy, the space available in the ventricle for filling is less. So filling is less. That's also impaired filling, and that's also heart failure. Okay. So these are causes for left and right heart failure. Now that we know the causes, if I am assessing the paper, I would definitely expect that you do mention about the clinical features of left heart failure and right heart failure. And particularly if you want to catch the attention of your paper corrector, do mention or highlight the most common cause for right heart failure as left heart failure. Examiners are very much fond of asking this question. Now, if the right side of the heart fails, basically either I'm not able to eject sufficient blood or I'm not able to fill. So one of the outcome of that is the stroke volume that is coming out from the right ventricle will come down. In the left side, the stroke volume coming out from the left ventricle will come down. What other problems we are going to face? The other problem is the impaired filling. So if the filling is less, the pressure in the right atrium increases because right atrium is getting blood, but it is not able to transfer to the ventricle because ventricular cavity size is already small because of concentric hypertrophy. So then if I'm not able to transfer blood from right atrium to right ventricle, right atrial pressure will start increasing. And if right atrial pressure increases, all the structures behind it in the hierarchy, their pressure will also increase. So superior vena cava pressure will increase, inferior vena cava pressure will increase. And if the superior vena cava pressure increases, you will see that as raised JVP. So raised JVP is a classical finding that you get whenever right side of the heart gets affected. Inferior vena cava pressure getting elevated also manifests as congestion in the liver. Why congestion in the liver? Again, that's pretty simple. You should know that liver receives the blood supply from two sources, the dual source of blood supply to liver. So liver gets blood supply from hepatic artery, that is from the systemic circulation, means that blood is coming from the aorta as a branch of aorta, that is hepatic artery, right? But there is one more source of blood supply, that is portal veins. And you know that portal vein is formed by fusion of, let us say this is a portal vein. It is formed by fusion of splenic vein that brings the blood from spleen and superior mesenteric vein. The superior mesenteric vein is bringing the blood from your intestine after the, it's like post-absorptive blood is what I call it as. Now what do I mean by this post-absorptive blood? We eat food. Our food contains toxins, useful nutrients, unwanted stuff, everything, right? Now it gets digested and we absorb, and when we absorb, we are absorbing nutrients as well as toxins. The toxins needs to be metabolized. Nutrients also need to be subjected to metabolism. And there is need for various conversions or change in chemical composition of those substances. And who is the major metabolic organ in the body? Liver. So these substances that are absorbed from the diet or from the food should not directly go to systemic circulation because they may be having toxins and even nutrients may not be in the final form that body needs. First it has to go to liver. So from the intestine, blood goes to liver, and the responsibility of bringing that blood from the intestine to liver through superior mesenteric vein is with the portal vein, And you may ask me, sir, what about inferior mesenteric vein? Inferior mesenteric vein joins the splenic vein. So all your intestinal blood is going to liver. And once the blood comes to the liver does all the metabolic process. And once the metabolic process is completed, now the ready blood is transferred to the systemic circulation through what we call as hepatic veins. So if the inferior vena cava pressure is already high because the right atrial pressure was high, then hepatic vein pressure will also be high. So if hepatic vein pressure is high, on one side blood is coming into the liver from the intestines, but it's not able to leave the liver easily to go into systemic circulation because ahead of it, everywhere the pressure is high. So the blood starts stagnating or congesting in the liver. And because blood is stagnating, the liver starts increasing in size. And this is what we call as congestive hepatomegaly. In pathology, you study it as CVC, chronic venous congestion. Nutmeg liver that they teach you. Why is this happening? It's happening because the pressure in the right atrium was elevated. So what are the findings we are getting when there is right heart failure? Superior vena cava pressure increases, that manifests as raised JVP. Inferior vena cava pressure increases and that manifests as congestive hepatomegaly or nutmeg liver or chronic venous congestion. This may eventually lead to the liver dysfunction. You may see jaundice, right upper quadrant pain and all, and it may even lead to cirrhosis if it is long running. Eventually what happens, if pressure inside the liver builds up behind that portal vein cannot push the blood into the liver because liver is already loaded with blood. So eventually the portal vein pressure will also increase, and when portal vein pressure increases, that's what we call as portal hypertension. So right heart failure can lead to portal hypertension. Portal hypertension is not always about cirrhosis of liver, right? Okay. So is that clear? So let me write down the findings that you should write for the right heart failure. So right heart failure will present with raised JVP, hepatomegaly because of the congestion in the liver, ascites is happening because of the portal hypertension, and you will also have pedal edema because inferior vena cava pressure is high. So you have difficulty to drain the blood from the lower limb veins. So you will end up with pedal edema. These are classical symptoms of right heart failure. Now, if the left heart fails, what am I going to expect? If the left heart fails, just like how right heart failure resulted in right atrial pressure going high, left heart failure results in left atrial pressure going high. And if the left atrial pressure starts going high, eventually pulmonary vein pressure will increase, pulmonary capillary pressure will increase, and the congestion, just like how right heart failure resulted in congestion of the liver, the left heart failure will result in congestion of the lungs, right? So now you have congestion of the lungs presenting as dyspnea or shortness of breath. And this dyspnea or shortness of breath generally gets worse on lying down in supine position. And what do we call it as? When you have shortness of breath on lying down or supine position? What do we call it as when you get shortness of breath on lying down or supine position? And covering the cardiomyopathies. Yes, we call it as orthopnea. So you may end up developing orthopnea. Another manifestation the congestion of the lungs can lead to is PND or paroxysmal nocturnal dyspnea. Now I have little lack of time because I have other major questions to cover, but don't worry, as of now just remember orthopnea and PND are symptoms of right heart failure. Left heart failure. I will discuss the mechanisms behind that elaborately in another video where we will be taking up more detailed discussion on heart failure. For now, just let's focus on writing the answer for Prof exam. Okay, let me tell you in simple terms instead of being an elaborate discussion. In simple terms, when you have left heart failure, you already have congestion of the lungs. Pulmonary capillaries are loaded with blood. Okay. On top of that, when you make the person lie down supine, the gravity is eliminated, so the blood that was there in the lower limb veins gushes to the right side of the heart, and from the right, where it will go? It will go to the lungs, right, through pulmonary artery. So the blood coming to the lungs increases when you lie down, because all the lower limb blood which was in the lower limb because of gravity is now coming back to the systemic circulation and reaching the lungs. So already lungs are congested, add more blood and make more congestion, you will become more short of breath, right? That's why lying down in supine position makes you short of breath in orthopnea. When I make myself upright, immediately there is gravitational pooling of blood in the lower limb, so the blood coming to the right heart comes down, so blood going to the lungs comes down, so congestion of the lungs decreases a little bit and the breathlessness feels little relief, right? PND has a little complex mechanism. In PND, what happens is the lungs get more congested when you go to sleep, and the congestion becomes worse 90 to 120 minutes after you have gone to sleep, not immediately lying down. If immediately on lying down, if I become short of breath, that is orthopnea. But if I lie down and I go into sleep and 90 to 120 minutes later, if I feel short of breath, then it is PND. It's there in the name, right? Paroxysmal means intermittent, nocturnal means nighttime dyspnea. This happens because the congestion increases that time, and that increase in congestion is not because of the venous blood coming back to the circulation. It's because of the edema fluid, right? You have edema in heart failure, and that edema fluid slowly, because when you lie down, where do we get edema generally in most of the patients? Pedal edema, gravitationally dependent areas. So During the daytime, patient was ambulant, walking around, so he developed pedal edema. But then night he sleeps. Now the gravity is not trying to pull the blood into the lower limb. Gravity's direction is tangential now. So the lower limb edema starts returning back to circulation, but edema does not return to circulation as quick as the venous blood returns to the heart. Venous blood will return to heart as soon as you change the position. But edema fluid will come slowly. So slowly it will come to circulation, goes to lungs, cause congestion. Second, 90 to 120 minutes later, after going to sleep, patient probably hits his first REM phase of sleep. And in REM phase of sleep, we start dreaming. And dreams often are accompanied by sympathetic nervous system overactivity. And whenever sympathetic nervous system is overactive, adrenaline is all peaking, so your heart rate increases. Increased heart rate makes it difficult for me to fill the ventricle. You may ask me why. When heart rate increases, either I have to cut short the duration of systole or diastole. Then only I can see. Let us say I am having 60 contractions or 60 cycles, cardiac cycles in each minute. 60 times it is contracting per minute. Now I have to, so in that case, I have 1 second time available for each cycle. But now I have increased the heart rate to 120. So now I have only half second available for each cardiac cycle. So when time available for each cardiac cycle comes down, I have to either cut short the systole time or the diastole time. You know what nature does? It first cuts down the diastole time. Only later systole time starts shrinking down when heart rate further increases. So initially the diastolic time gets shortened. So time available for me to fill the ventricle, because we fill in diastole, that is coming down. So I have less time to fill. So if I have less time to fill the ventricle, I'm transferring less blood from left atrium to ventricle. So more and more blood is staying back in the left atrium. So left atrial pressure will start increasing more. So pulmonary vein pressure will start increasing more. Pulmonary capillary pressure will start increasing more. So two things are there for the PND. The edema fluid slowly returns to the lungs, and 90 to 120 minutes later, you start dreaming, your sympathetic nervous system activity is high, diastolic time comes down, so transfer of blood from atria to ventricle comes down, atrial pressure starts going up, all add up to worsen the congestion of the lungs, and that's why you wake up with dyspnea 90 to 120 minutes after you have gone to sleep. In orthopnea, if I make myself supine and short of breath, the moment I make myself upright, I feel good. I feel better. But in case of PND, the onset of dyspnea is not immediate, 90 to 120 minutes later. And when I wake up from shortness of breath, I'm not going to feel relieved immediately, because the edema fluid that returned to circulation is not going back to the lower limb immediately if I wake up. It takes time, right? So usually you feel relief 30 to 45 minutes after you've woken up, took an upright stance. Most of the time patient walks to the window, because the shortness of breath, general perception is lack of air. They feel air hunger. They stand next to the window, try to feel comfortable, and 30-40 minutes later they feel comfortable, they go back to sleep. But the cycle might repeat. 90 to 120 minutes later, again same story keeps repeating. That's why it is called as paroxysmal or intermittent nocturnal dyspnea. I want you to remember one important point. This is more of an MCQ point or a bedside discussion point. Among the symptoms that I've listed for the left heart failure, PND is the most specific symptom of left heart failure. Most specific symptom of left heart failure. If at all you have a heart failure bedside case, your teachers are very much likely to ask what is the most common cause for right heart failure. They are also very much likely to ask the mechanisms behind orthopnea, PND, and what is the most specific symptom of left heart failure. Orthopnea can happen in patients with diaphragmatic palsy, massive ascites, massive obesity, or even sometimes after heavy meal. Most of you might have experienced it. So orthopnea is not specific, but PND is specific to left heart failure. So this is one classification, heart failure into right and left. But as I have already told you, majority of right heart failure are because of left heart failure, and that's why in a general discussion, heart failure means we are talking about left heart failure. So there is another classification of heart failure which is centered around left heart failure, and that is based on the ejection fraction. So you can put a title saying classification based on ejection fraction. And to understand that, first we need to understand what is ejection fraction. So normally in the ventricle, we fill the blood, like let us say this is the left ventricle we are looking at. And in the left ventricle during diastole, I fill the blood and I eject it during systole. So the amount of blood ejected during each systole is called as stroke, right? Amount of blood filled during each diastole is called as filling volume. And the amount of blood that is there in the ventricle after each systolic ejection is called as end systolic volume. And both end systolic volume and filling volume combined together is called as end diastolic volume, right? So let me put some mathematical terms here. End diastolic volume is the amount of blood present in the ventricle at the end of diastole. And how much is present? One, I just completed a systole, so I ejected some amount of blood, something is remaining with me, and then some amount is filled by the atria. So that is filling volume, this is end systolic volume. Both together is there at the end of diastole in the ventricle. So it is the end systolic volume plus the filling volume. Okay. Now out of this, I eject some percentage of, like normally the resting end diastolic volume is around 120 ml, 120 to 125 ml. Out of it, some amount of blood gets ejected in each systole, and that is approximately around 70 ml. Now if I express in terms of percentage, what percentage of blood that was there in the ventricle at the end of diastole got ejected as stroke volume, then we will call that percentage expression as ejection fraction. So ejection fraction is nothing but EF stands for percentage of end diastolic volume ejected as stroke volume. So what will be the formula? EF is equal to stroke volume divided by end diastolic volume, but I want to express it in percentage, so I have to multiply it with 100. So that gives me the ejection fraction. So normal ejection fraction ranges from 60 to 70%. That means if I give 100 ml of blood to the ventricle, at the end of diastole, ventricle has 100 ml of blood. That includes the volume that got filled from the atria and the volume that was already there remaining from previous systole. Combined is end diastolic volume. Out of it, if my ejection fraction is 60%, then I will be able to eject 60 ml out of it, right? 100 ml is there as end diastolic volume. 60% of that is 60 ml. That becomes stroke volume. 60 ml becomes stroke volume, right? Got the gist of what is ejection fraction. Now tell me, what is the biggest determinant of ejection fraction? Who decides how much is the ejection fraction? Simple. Okay. Let me take this bottle. Okay. So this is some talc bottle. In this, let me fill water. Okay. Let us say I fill 100 ml of water and then I squeeze it. How much ml comes out? 100 ml is there when filling is over. Or there already 30 ml was there. I filled 70 ml as filling volume, 30 ml end systolic. All that's fine. I have 100 ml at the end of diastole. Now I am doing systole, right? I contract, I push or squeeze, and then some amount of water got ejected from this bottle. That water is your stroke water. Okay. If I squeeze hard, more amount of water will get squeezed out. If I squeeze less hard, less amount of water will get squeezed out, right? 100 ml was there. If I squeeze hard, I may be able to bring 90 ml out. In that case, what will be my ejection fraction? 90%. If I squeeze less hard, 30 ml will come out. Then my ejection fraction becomes 50%. So what decided how much will come out of this chamber? Force that I am applying. In the heart, who is applying the force? Left ventricular muscle mass. So if muscle contracts more forcefully, I will have more ejection fraction. If the muscle's force of contraction is less, I will have less ejection fraction. So it is the muscle that determines the ejection fraction. And when I said 60 to 70%, right, is that fixed? No, it is the resting ejection fraction. If I start running, I need more stroke volume, right? If end diastolic volume is fixed, how will I get more stroke volume? If ejection fraction is also fixed? No, ejection fraction is not fixed. At a resting condition, your muscle is able to contract with some force, and that force is giving you 60 to 70% ejection fraction. But when I start exercising, sympathetic nervous system gets activated, right? So adrenaline, noradrenaline, dopamine, they will come and stimulate the heart to contract with more force. So when heart contracts with more force, ejection fraction increases. And that is how I'm able to get more stroke volume, more cardiac output during physical activities, exertion. But then also we learn one more point here. The muscle is the biggest determinant. What if I kill the muscle? Ejection fraction will come down. So because of that, stroke volume will come down. Even if you give me 120 ml end diastolic volume, I've killed the muscle, so it can't generate sufficient force. So because of that, instead of 70 ml, I may be able to eject only 50 ml, 40 ml or 30 ml as stroke volume. So why I got low stroke volume? Because the ejection fraction is now less, right? So what does this indicate? Whenever ejection fraction is less, the problem is in ejection. I'm not able to eject well. If I have heart failure where ejection is fine, means muscle is fine, its force of contraction is good, but still I have heart failure, that means the problem was not in ejection, problem was in filling. So ejection fraction helps you to identify whether the patient you're seeing with the signs and symptoms of heart failure, whether he has a problem in ejection or whether he has a problem in filling. Now tell me, I'm waiting for your comments. Tell me whether if I have a problem in ejection, can I call it a systolic heart failure? And if I have a problem in filling, can I call it as diastolic heart failure? Perfectly makes sense, right? We eject in systole. So if that is where it is impaired, then I have systolic heart failure. If filling is the problem, that happens in diastole, so it's a diastolic heart failure, right? So impaired ejection can also be called as systolic heart failure, and impaired filling can also be called as diastolic heart failure. Got it? So that's why ejection fraction is a very important tool for the classification of heart failure, not for diagnosis. Because diagnosis is based on the biomarkers and the clinical features. But to understand whether it is systolic or diastolic, or whether it is impaired ejection or impaired filling, we need to look at the ejection fraction. So if ejection fraction is less than 40%, we will call it as heart failure with reduced ejection fraction. And if EF is more than 50%, more than or equal to 50%, we will call it as heart failure with preserved ejection fraction. If the EF is between these numbers, we can call it as heart failure with mid-range ejection fraction. Okay. Now, as a UG student, as long as you're able to quote preserved and reduced, fair enough. It's more than enough. Okay. So heart failure with reduced ejection fraction is usually abbreviated as HFrEF, reduced REF, HFrEF, and heart failure with preserved ejection is usually abbreviated as HFpEF. Some books may quote it as HFnEF, normal ejection fraction. Ejection fraction is not low, that's what preserved means, right? So heart failure with reduced ejection fraction is equal to systolic heart failure, and heart failure with reduced ejection fraction is equal to diastolic heart failure. Now, if you ask me what is the most common cause for systolic heart failure, it is ischemic heart disease. You kill a muscle, it can't contract well, ejection fraction will come down. That's why you might have had relatives or your family members, elderly, diagnosed with IHD with low EF. Very often they develop congestion of the lungs. You have to take them to the hospital, give a diuretic job, put a very strict restriction on salt and fluid intake, and then eventually the condition progresses. We might have to start, the doctors might start talking about cardiac transplantation and all of that, right? The most common cause for diastolic heart failure is hypertension. The other cause for diastolic heart failure is hypertrophic cardiomyopathy. The other cause for systolic heart failure is dilated cardiomyopathy, right? So these are methods of classifying the heart failure. Okay, now that we know the two classifications of heart failure, let us also look at the pathophysiology of heart failure. Exactly what happens when heart fails. So two things happen when heart fails. Number one, the ejection is impaired or filling is impaired, and outcome of both of them is reduced stroke volume. If the ejection is impaired, then force of contraction generated is less, ejection fraction is less, so less stroke volume. If filling is impaired, force of contraction is good, but then amount available in the ventricle to eject itself is less. So in both cases, I have low stroke volume. So whenever there is heart failure, one of the things you can expect is a decrease in the stroke volume. And when stroke volume decreases, I do expect this to lead to decrease in BP, because systolic BP is directly proportionate to stroke volume. But as we know, even from our valvular heart diseases, there's a counter-regulatory mechanism in the body, that is RAS. RAS will get activated. So decreased BP lead to increased RAS activity. And once RAS gets activated, right, so you have angiotensin 2 and aldosterone coming into picture. And what angiotensin 2 does, angiotensin 2 will try to normalize the BP. How? By causing vasoconstriction. So angiotensin 2 causes vasoconstriction. And vasoconstriction means we're talking about the constriction of aorta and its branches, that is systemic blood vessels. And if they get constricted, pressure inside the aorta and systemic blood vessels increased. Now left ventricle has to put more effort to push blood into a high pressure vessel. So work done by the left ventricle increased. What increased? Afterload or preload? Preload is end diastolic volume. Afterload is the resistance given by aorta and its branches. And now that pressure inside the aorta and its branches is high, they are giving more resistance. So afterload increased. Now, is this good for the heart? No, your heart is already failing. It's not able to handle the workload. And you increase the workload, it fails more. Simple, right? Now, aldosterone, at least that will give me a rescue. No. What aldosterone does? It increases sodium and water reabsorption at kidney. So because of that, the circulating blood volume increases, because more and more water and sodium is reabsorbed. If circulating blood volume increases, more blood reaches the heart. If more blood reaches the heart, then at the end of diastole, heart will have more blood, because more blood is coming to the heart. And end diastolic volume is nothing but our preload. So there is increase in preload. So already heart is failing, it's not able to eject it, or there is no space to fill this blood, but you are increasing this blood. So both increase in afterload and preload because of this RAS are harmful to a failing heart. Unfortunately, it happens. It should not have happened, but nature is not perfect. But then there's also one more change happens. As we just learned, what are the symptoms of right heart failure? Raised JVP, hepatomegaly, all of that. Why is it happening? Right atrial pressure got increased. What are the symptoms of left heart failure? Orthopnea, PND, dyspnea. Why is it happening? Congestion of the lungs. Why lung got congested? Because left atrial pressure increases. So whether it is right or left, atrial pressures increase. So there is increase in atrial pressures. Increase in atrial pressures. And when atrial pressures increase, atria have a mechanism of unloading their pressure. You know what they do? They will tell the kidneys, pressure on us is very high. Just like how you express your stress to your close friend, hoping that he will help you. Similarly, atria is telling the kidneys, we are loaded with pressure, please unburden us. You excrete more urine so that the pressure on us comes down. And what is that signaling molecule that they send? Natriuretic peptides, right? Like ANP, BNP. We will call them as natriuretic peptides. Like ANP, BNP, and these do exactly opposite of RAS. RAS causes vasoconstriction, natriuretic peptides cause vasodilatation. So by doing vasodilatation, they decrease afterload. So they unburden the failing heart. Second, they increase sodium and water excretion. It's there in the name, no? Natriuretic peptides. Natrium means sodium. Uresis means lose. These are the peptides which make you lose sodium, and you know sodium will never go alone. It will always take water with that, being an osmotically active substance. So you have increased sodium and water excretion. So because of that, there is decrease in circulating blood volume. So you will have decrease in end diastolic volume. You will have decrease in preload. So these changes are beneficial for a failing heart. They slow down the failure because they're reducing the burden on the right. So now you might be wondering why sir is talking about pathophysiology. Of course, it has a relevance to the pharmacological management, because now that we know RAS is harmful, what should I do with RAS if I have a patient with heart failure? Block it. Agree? But what should I do with these natriuretic peptides? They are beneficial, right? So I want to support it, facilitate its action. So either I can use natriuretic peptide analogs, or there's one more pharmacological way of dealing with drugs. If I want to increase the activity of any of the drugs, like for example, I want to increase the activity of acetylcholine, then what do? Do I actually give acetylcholine to the patient? No, right? So then what do? We identify something that breaks down the acetylcholine, right, to choline and acetate. What is that? Acetylcholine esterase. We block it. By blocking it, we can increase the duration of availability of acetylcholine. Simple. So same thing we can apply here as well. So with the research, we have found out that the natriuretic peptides like ANP, BNP that are produced in the body, they are broken down to inactive peptides by an enzyme called as neprilysin or neutral endopeptidase. So if I block this, I can increase the ANP and BNP activity. I can make the patient pass more urine, lose more sodium, lose more water, cause vasodilatation, and reduce the burden on the heart. So that's why if you look at your pharmacology books and look at the drugs used for heart failure management, it's like RAS blockade, ACE inhibitors or ARBs, spironolactone, and neprilysin inhibitors, right? Clear? So now that we know the pathophysiology, let me quickly jot down the diagnosis and then management. Diagnosis and management. So in the diagnosis, just write simple, keep it plain and simple. The diagnosis is based on signs and symptoms of heart failure plus elevated BNP or pro BNP levels. And if you want, you can highlight the BNP or pro BNP level. They are considered as the biomarkers for heart failure. Biomarkers for heart failure. Clear? Now that we know about the diagnosis as well, let us talk about management. Okay, I will keep the management simple. I will not get into the goal directed management now because it's for the theory exam. So what is expected from you on a written answer for heart failure? Number one, treat underlying cause. If there is ischemic heart disease, like if someone presented with MI and that has caused heart failure, do an angioplasty, open the blocked blood vessel, re-establish the blood flow. Hopefully some amount of myocardium starts functioning again, ejection fraction improves, and the symptoms of heart failure will come down. So treat underlying cause for sure. Okay, apart from that, what else we need to do? Pharmacotherapy. And when it comes to pharmacotherapy, the first thing I want you to write is ACE inhibitors or ARBs. Why? Because RAS is harmful, we are blocking them. Second, I forgot to actually address one more important point. The decreased BP also leads to activation of sympathetic nervous system, and sympathetic nervous system mainly brings adrenaline, noradrenaline, right? So they also cause vasoconstriction. So don't you think that's also harmful? That needs to be blocked. How do I block it? Beta blockers. Beta blockers for blocking the sympathetic nervous system. Third, I can give spironolactone to block aldosterone because it's part of RAS and that is harmful. Okay. Fourth, very important, your examiners are keenly looking for this in your answer. New class of drugs, nothing to do with cardiology directly. They were introduced as antidiabetics, but studies have shown that they reduce the cardiovascular mortality in IHD as well as heart failure patients, and they are beneficial. And what am I talking about? Antidiabetic drugs? Yes. SGLT2 inhibitors. Good. SGLT2 inhibitors. So these are the standard drugs used for heart failure patients. Apart from that, we can consider ARNI. ARNI. So what ARNI refers to? ARNI refers to angiotensin receptor plus neprilysin inhibitors. Means a combination of drugs that inhibit angiotensin receptor, that is ARB, right, plus neprilysin as well. Currently, the one combination that is available in India and you should write it is valsartan. Valsartan is an ARB, as you know, plus sacubitril. Sacubitril is the neprilysin inhibitor. Is it for all heart failure patients? No. So you can mention that it is for heart failure with reduced ejection fraction with EF less than 35%. Normally less than 40% is how we define as heart failure with reduced ejection fraction. But if EF is less than 35%, then we have to give ARNI instead of just AC inhibitors or ARPs. If it is 35% plus, then you can just try to manage with AC inhibitors or ARPs. Okay. Now that's about pharmacotherapy. Remember one standard point mainly for your Viva OSCE discussion. They asked you which drugs are known to increase cardiovascular mortality in heart failure. That includes inotropic agents like digoxin and milrinone. They generally increase the mortality because they are burdening the heart. They are improving the symptoms but burdening the. Okay, so that's for your Viva OSCE. No need to write in a theory exam. Okay, now advanced treatment. This is what some of the university papers include, like define heart failure, discuss classification, diagnosis and management. Write a short note on the advanced management of heart failure. So what else we have? Like despite these medications, if the condition progresses, what else we can offer? So one of the things we can offer for these patients is ICD. ICD, you know, it stands for implantable cardioverter defibrillator and cardiac resynchronization therapy. Cardiac resynchronization therapy. Okay, I'm not discussing the indications, contraindications and all right now. It's only for the MCQ exam. For the theory, just write it. See, I'll tell you the logic behind this. The most common reason why patients of heart failure die is not hypoxia. Many of them die outside of the hospital because of development of ventricular tachycardia and ventricular fibrillation. So lower the ejection fraction, higher is the risk of developing VT and VF. So to prevent that, we implant a defibrillator so that if they develop a VT or VF, it will shock and correct it. And some of them may be having left bundle branch block. And that left bundle branch block disturbs the synchrony between right ventricle and left ventricle. So we try to bring that synchrony back by using a pacemaker-like device. We call it as cardiac resynchronization therapy, right? For now, as long as you remember this much, it's enough. Second is, we have something called as left ventricular assist device. It stands for LV, left ventricular assist device. So if your left ventricle is not able to eject the blood, we will hook it to a device, means a tube connected to left ventricle that will take the blood from the left ventricle, and we will not ask the left ventricle to eject it. We will make this tube to eject the blood into the aorta. It's like, let us say this is aorta and this is left atrium, this is left ventricle, as you know. So what I will do is I will connect a tube between left ventricle and aorta, which is now connected to a pumping system. So what this will do is, once the blood comes to the left ventricle, this system or this device will take it and it will pump the blood into the aorta. So left ventricle's job is eliminated. It's called as left ventricular assist device. If you Google, you will be able to see beautiful images of this. On YouTube, there are influencers who are living with left ventricular assist device. They often keep posting their updates. Okay, and one more solution we can offer for these patients of heart failure is cardiac transplantation. This heart is failed. If someone gives you another heart, good. Of course, people will say, I'll give you the heart, but nobody gives. A living person, of course, cannot donate a heart. It has to be a brain dead individual. Then we can do a cardiac transplantation, right? So this is about heart failure, right? So I'm quickly giving you the summary, the points that you need to mention. The conceptual definition you should write: impaired ventricular filling or ejection. Technical definition: heart failure ke symptoms and elevated biomarker like elevated NT-proBNP. Classification: right versus left, and then also write the classification into reduced and preserved ejection fraction, Numbers are important. Don't jumble the numbers. Keep that clearly mentioned. Pathophysiology basically mentioned that one side stroke volume decreases, other side atrial pressure increases. Decreased stroke volume activates RAS and sympathetic nervous system, and atrial pressure increasing activates ANP BNP. ANP BNP is beneficial, so we want to increase their action by inhibiting neprilysin. RAS and sympathetic nervous system are harmful, so we block them with ACE inhibitors, ARBs, aldosterone receptor blockers, spironolactone, and the beta blockers. Okay. Now the next topic that I'm going to discuss is cardiomyopathy. Define cardiomyopathy, describe different types of cardiomyopathies, right? So we'll follow the same template that I followed so far. Here they are directly asking definition. So let me begin with definition. Even if there is no definition, I would like you to write 1 or 2 sentence introduction to make the entry into the answer beautiful. Okay. So what is cardiomyopathy? Myo means muscle, cardio means heart muscle, pathy means pathology. It's simple, right? So the pathology of heart's muscle. Now, can I say yesterday we discussed about aortic stenosis. There we had concentric LVAD. What is getting affected? Muscle. Left ventricular hypertrophy. Muscle is hypertrophy. So can I call that as cardiomyopathy? So today also we discussed about concentric hypertrophy because of hypertension, pulmonary hypertension on the right side. Can I say that the ventricular hypertrophy should be called as cardiomyopathy? No. Then what is cardiomyopathy? Okay, another example. If I have ischemic heart disease and blood supply to a ventricular muscle area is down and that muscle dies. Who died? Muscle died. Muscle pathology. Can I call that as cardiomyopathy? No. If muscle dies because of lack of blood supply, that is ischemic heart disease. If muscle becomes hypertrophic because of a obstruction or valve problem, it's a valvular heart disease. We will not call them as cardiomyopathies. The muscles change is just a remodeling or a manifestation of the other major pathology. But what if the muscle becomes atrophied or hypertrophied without such causes, without coronary artery disease, without the obstruction or valvular heart disease? Then we will call it as cardiomyopathy. So the definition is disorders of cardiac muscle in the absence of ischemic heart disease, valvular heart disease, and hypertension, including pericardial disease and hypertension. Then we will call it as cardiomyopathy. So if the muscle gets affected without hypertension causes the LVH, that's hypertensive heart disease. Aortic stenosis causes LVH, it is valvular heart disease. Ischemic heart disease causes dilatation of the left ventricle, it is ischemic heart disease. But nothing of this is there, but still either heart is dilating or becoming hypertrophied or it's not able to relax. Something is wrong with the cardiac muscle, but these problems are not responsible. Then we will call it as cardiomyopathies. Now, how do we classify cardiomyopathies? The cardiomyopathies are classified into 3 major groups. So what are those 3 major groups? The first one is dilated cardiomyopathy or DCM. The second one is hypertrophic cardiomyopathy or HCM, and the third one is restrictive cardiomyopathy or RCM. Okay, hypertrophic cardiomyopathy and the dilated cardiomyopathy are very common. Dilated cardiomyopathy is most common clinically apparent cardiomyopathy, and hypertrophic cardiomyopathy is overall most common cardiomyopathy, though patients are asymptomatic and they are not usually diagnosed. That's why I don't say clinically apparent. Restrictive cardiomyopathy is relatively rare. Okay. Here only I want you to know one important point. The restrictive cardiomyopathy mainly affects right ventricle more than left ventricle. Hypertrophic cardiomyopathy affects left ventricle more than right ventricle. Dilated cardiomyopathy also affects left ventricle more than right ventricle. So you can think of it like this. The dilated and hypertrophic cardiomyopathy are diseases of left ventricular muscle, and restrictive cardiomyopathy is mainly a disease of right ventricular muscle. Okay, clear? So you can mention this as the most common cause, and most common cause for clinically apparent cardiomyopathy. So we will begin discussing first the dilated cardiomyopathy. What do I mean by dilated cardiomyopathy? So when your left ventricular dilatation happens, usually ventricles dilate because of the increasing volume or pressure inside them. To compensate for the volume increasing the ventricle or pressure, they dilate. That's what we learned, right? Boyle's law. But if ventricle dilates in the absence of any increase in preload, afterload, any increase in volume, no obstruction, no problem, but still it just goes on dilating, then we will call it as dilated cardiomyopathy, right? So left ventricular dilatation in the absence of IHD, valvular heart disease, and hypertension. So what can cause left ventricle to dilate? Basically, it is because of the atrophy of the left ventricular muscle that it is dilating, and if it is atrophying, the force of contraction is going to come down. So they will present with impaired ejection. So basically, that's a form of heart failure. The causes wise, the most common cause is a toxin, and that is alcohol. Alcohol. So some of you may be planning that, okay, sir, exam khatam, last day of the exam, I'm gonna drink nicely. So be informed that every drink that you consume is taking you a millimeter closer to development of dilated cardiomyopathy. So if you keep accumulating alcohol-induced myocardial injury, eventually one day you will have dilated left ventricle, right? So think about it. Alcohol is the most common cause. It can also be familial or inherited. And when it is familial or inherited, the most common mutation responsible is mutation in a gene called as titin. Titin is coding for the gene is called TTM. The protein is titin. Titin is a muscle protein. Apart from that, other toxins are also known to cause dilated cardiomyopathy. That includes cocaine, a natural upgrade from alcohol for many people, right? Cocaine is also going to cause dilated cardiomyopathy. Okay, what else I can quote here? The peripartum or puerperal cardiomyopathy that we call is also a form of dilated cardiomyopathy. So the list can go on and on and on. Like hemochromatosis is one more. You don't have to write an elaborate list. What is expected from you is you should mention alcohol, you should mention familial, you should mention cocaine. Drugs is something that you should mention. And when it comes to drugs, cardiotoxic drugs like doxorubicin, basically cancer chemotherapy drugs, daunorubicin. And I'll tell you a hack that many of students used to use during my days is like keep writing all these chemotherapy drugs as the causes for dilated cardiomyopathy. Your teachers will not be able to question you or refute, because most of the chemotherapeutic agents, there will be some or the other published studies saying that there are at least case reports of patients presenting with heart failure or dilated cardiomyopathy. But at least the minimum expected from you is doxorubicin, daunorubicin. If some other drugs come to your mind from the chemotherapy, omit it. Teachers may not object to it. So these are causes. Now, what are the clinical features that I'm expecting in dilated cardiomyopathy? The clinical features are basically the left ventricle dilates because of the atrophy or thinning of the left ventricular muscle mass. So its force of contraction comes down, ejection comes down, stroke volume comes down. You have the same symptoms of heart failure. So you can write the clinical features similar to left heart failure. Basically, the patient present with left heart failure. Remember, in heart failure itself, I mentioned that dilated cardiomyopathy can present as left heart failure. So it's like a patient presents with left heart failure. We will think of hypertension, IHD, dilated cardiomyopathy, hypertrophic cardiomyopathy. These are the causes. I will investigate to find out the cause. And if I do coronary angiography and it does not show any IHD, and BP is recorded and it's not suggestive of hypertension, and the telltale signs of long-standing hypertension like LVH are not there, then I would come to the conclusion that okay, I may be dealing with dilated cardiomyopathy when LV is dilated and visible on the echocardiography. So in terms of management, again, for all cardiomyopathies, just mention two statements: treat underlying cause and treat heart failure. So treat underlying cause. What is the underlying cause? Alcohol is the most common cause, so try to do a de-addiction service for the patient, refer to a psychiatrist, let him try to come out of alcohol. That will help him. Plus, right now he has got heart failure, so I have to follow the standard heart failure treatment, that is ACE inhibitors, ARBs, beta blockers, all of that, and if required, cardiac transplantation. So treat underlying cause and heart failure. So no specific treatment for dilated cardiomyopathy as such. Okay, next I will talk about restrictive and then we will go to the hypertrophic. So when we talk about restrictive cardiomyopathies, you have to remember only one thing here. Restrictive cardiomyopathy refers to restriction of ventricular filling. Now that restriction of ventricular filling can happen because of two things. See, I want to fill the blood into the ventricles, left and right ventricle, from right atrium to right ventricle, left atrium to left ventricle. And to fill that blood, ventricle has a prerequisite. What is it? It has to do isovolumetric relaxation and lower its pressure. Then only blood will move from atria to ventricles. Now, who can stop its isovolumetric relaxation? One thing that can stop its isovolumetric relaxation is pericardium. If pericardium is stiff and it's not letting the ventricle expand, it will restrict. And that condition we will call it as constrictive pericarditis. When pericardium restricts the ventricular filling, we call it as constrictive pericarditis. In fact, the term constrictive pericarditis is a misnomer. Pericardium is not constricting the ventricle. It's just becoming stiff, not letting the ventricle expand. The second thing that can stop the ventricle from expanding is ventricle itself. What if the muscle is stiff and it is not letting ventricle relax? So when muscle is the problem, not the pericardium, we will call it as restrictive cardiomyopathy. When muscle becomes a problem, one condition it can become a problem, not let muscle relaxes. If it is fibrosed, we term it as endomyocardial fibrosis. The endocardium that is lining inside and the myocardium both get fibrosed. So it is stiff. It's not a muscular tissue anymore. So it can't dilate well. Right? Then the other condition that can lead to the restriction of the muscle relaxation is, what if I load this muscle with substances that are not supposed to be there in the muscle? Then it may not be able to relax. So the cardiac muscle is not a storage organ. Your skeletal muscle is also a storage organ. It stores the glycogen. But what if I use cardiac muscle as a storage organ and I store glycogen here? Yes, your glycogen storage diseases, where you start storing the glycogen in liver, abnormal amounts and abnormal forms of glycogen in liver, and sometimes in cardiac muscle. So in your biochemistry, you might have studied that various glycogen storage disorders present with heart failure or cardiac myopathies, right? And it need not only be glycogen storage disorder, it could be lipid storage disorder, it could be other storage disorders like iron storage disorder, that's hemochromatosis. All of them, when the cardiac muscle is abused as a storage organ, which it is not, it may not be able to relax. And you have restrictive cardiomyopathy. So what you have to remember is storage disorders. That's it. Whatever storage disorders come to your mind, write down. Some of them may not be causing, but it's fairly okay. The teachers will still give you the decent amount of marks. So restrictive cardiomyopathy is basically impaired and it affects right side of the heart more than left, because the left side of the heart is quite muscular. So it takes larger amount of stuff to be stored in them to make them dysfunctional. The left ventricle, the right ventricle is not as muscular as left. So a minimal amount of storage and it loses its function. That's why right is affected more easily. So impaired right ventricular relaxation in the absence of, usually what stops the right ventricle from relaxing isovolumetric relaxation, it is the pericardium, that is constrictive pericarditis, in the absence of pericardial disease. Pericardium is stopping the right ventricle from relaxing, then it is constrictive pericarditis. It's not restrictive cardiomyopathy, right? So in terms of causes, you can mention storage disorders. Examples you can quote: glycogen storage disorders, hemochromatosis. Hemochromatosis can present with both dilated as well as restrictive cardiomyopathy. Then amyloidosis. So that is one. Another example we can mention is endomyocardial fibrosis. Endomyocardial fibrosis. I still have lag on your comments. So I might have missed some of your queries. Please don't hesitate. My Instagram ID is Dr. Santhosh P. You can search for it and you can shoot a message on my Instagram, and I'll find time tomorrow or day after tomorrow and I'll reply to all of your queries. Okay. So these are the causes I wanted to mention. Storage disorders. If you can name some glycogen storage disorders, mention it. And then endomyocardial fibrosis. Okay. Now in terms of clinical features, they present with right heart failure. So what are the symptoms of right heart failure? You can elaborate. Raised GVP, hepatomegaly, ascites, fetal ectoma. You can elaborate. Management, treating the underlying cause. Means for some diseases we have treatment. Like for some glycogen storage disorders, enzyme replacement therapies are there. For some forms of amyloidosis, treatment exists. So if it is treatable, treat the underlying cause. If you don't have a treatable underlying cause, you have cardiac transplantation as a choice. Though the problem is, because if you're not solved the underlying cause, then even the transplanted heart may end up developing the disease. So that will also eventually develop restrictive cardiomyopathy. But at least for a few years, they can expand the survival of the patient. This is about your restrictive cardiomyopathy. Restrictive cardiomyopathy is what? Dilated cardiomyopathy is where without a clear cause, your left ventricle starts atrophying and dilating. Restrictive cardiomyopathy is what? Without a pericardial pathology restricting, the right ventricle fails to relax during diastole. Right? So here you will have impairment in right ventricular filling, resulting in reduced right ventricular stroke volume. So that is classical right heart failure. That to diastolic failure. Here it is systolic failure. The ventricle is atrophied and dilated. It fails to contract and eject the blood well. So they will have heart failure with reduced ejection fraction. Okay. The next one we have is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. Interesting topic indeed. So I want to begin by mentioning few important epidemiological points that your teachers are interested. It is most common cardiomyopathy overall, though most cases are asymptomatic. Most cases are asymptomatic. That's why among the diagnosed cases, what is the most common? Dilated cardiomyopathy. But if you screen the whole population, you will find out that hypertrophic cardiomyopathy is more common. How common it is? It affects 1 in 500 births. And this cardiomyopathy cannot be acquired. Your restrictive and dilated can be acquired. You want to dilate the heart, either you should be born with the titin mutation or other mutations, or you drink. You drink heavily and you will have dilated cardiomyopathy. Bada dil mil jayega. You want restrictive cardiomyopathy, either you have to be born with those glycogen storage disorders, or you can load yourself with iron and you will develop hemochromatosis and you may have restrictive cardiomyopathy. But hypertrophic cardiomyopathy is purely inherited. You can't acquire it. It affects 1 in 500 births. It is most commonly due to mutation in beta myosin. Titin mutation was responsible for dilated. Beta myosin heavy chain gene mutation is responsible for hypertrophic cardiomyopathy. So what happens in hypertrophic cardiomyopathy? You have a concentric type of LVH. Normally when we get concentric LVH, when there is increase in afterload, remember that. AC, PE. Afterload increase, concentric. Preload increase, eccentric. AC, PE. So in the absence of increased afterload, afterload increases when aortic stenosis, systemic hypertension, right? Those conditions. But those are not there. But still you develop concentric hypertrophy. It's like I have not gone to gym, but still I'm developing muscle. That's what is happening with the left ventricle. Concentric hypertrophy in the absence of increased afterload, like hypertension, aortic stenosis, coarctation of aorta and all. So what other points I want you to write here is, see, genetic, only one cause, that is beta myosin heavy chain mutation. And those who are born with this, slowly left ventricle start developing hypertrophy, concentric type of hypertrophy, and it will lead to some problems. We'll discuss about that. The point I want you to mention here is that the hypertrophic cardiomyopathy is the most common cause for sudden cardiac death in young individuals, and athletes. And I also want you to remember that the sudden cardiac death refers to the death because of a cardiovascular problem without major forewarning symptoms. It's like I had heart failure multiple times. I was getting admitted every second week, third week. Story was going on for last 1 year, and then I died. Now it's not sudden cardiac death. I went to sleep. Next day morning, family finds out that I'm no longer there. That's sudden cardiac death. And the sudden cardiac death, overall, the most common cause is MI or ischemic heart disease. Like the story you hear that Dadaji went to sleep, and next morning when we went to wake him up, all his limbs were cold. He was not responding. Mostly he died because of a massive MI during the sleep. So ischemic heart disease is the most common cause for sudden cardiac death overall. But in young, where IHD is now increasing, but it's not still a leading cause. So in young people and athletes, sudden cardiac death mostly happens because of hypertrophic cardiomyopathy. Young individuals and athletes. So can anybody tell me what are the other causes for sudden cardiac death in young individuals and athletes? You keep hearing these stories, right? Like he was just 30, 25, died suddenly. Like a 25-year-old PG, did the ward rounds, and then he was in the nursing station writing the notes, he collapsed there and died. Hypertrophic cardiomyopathy is one cause. Yes. So you have other causes like the congenital long QT syndrome and arrhythmogenic right ventricular dysplasia. So the list goes on. Okay. So what happens here is patients slowly develop concentric LVH with asymmetric septal hypertrophy. So I'll tell you what exactly that means. So these people, like let us say that I'm looking at the left side of the heart. This is the left ventricle. This is aorta, and this is left atrium, right? This is how I usually sketch my heart. Here you will have the mitral valve. Here you will have the aortic valve. And in this ventricle, the part of the ventricle which leads into aorta, this part of the ventricle is called as left ventricular outflow tract. Left ventricular outflow tract. And this part of the ventricle where blood actually comes from the atria is called as left ventricular inflow tract. Okay. Now what is happening? Slowly these people are developing concentric hypertrophy. So inside the ventricle, the muscle mass gets added, making the ventricular cavity smaller. But then this hypertrophy affects the septum asymmetrically. Means if I do a septal hypertrophy symmetrically, this is how it is going to look like. Everywhere the uniform increase in the thickness. This is what is expected. This is what I see in most of the concentric LVH because of hypertension, aortic stenosis and all. But here the septum becomes asymmetrically hypertrophied. It usually hypertrophies more in the left ventricular outflow tract region. Hypertrophies more in the left ventricular outflow tract region. And because of this, it will create the obstruction of blood from LV to aorta. It will start obstructing, right? So what are the changes we are noticing here? One, we are getting concentric LVH with asymmetric septal hypertrophy, usually abbreviated as ASH or ASH. Usually abbreviated as ASH. And because of this asymmetric septal hypertrophy, it may lead to left ventricular outflow tract, that area where blood actually moves out from LV to aorta, getting obstructed, left ventricular outflow tract obstruction. And whenever it results in left ventricular outflow tract obstruction, that time when it causes obstruction, I will call it as HOCM. So what HOCM refers to? Hypertrophic obstructive cardiomyopathy. So HOCM is not a different disease per se. It is just an extended version of hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, where the septal hypertrophy has resulted in obstruction of blood from moving from left ventricle to aorta, then we will call it as HOCM. Okay. So they are not two different entities. Okay. So that's why in many of your MCQs, the most common cause for sudden cardiac death in young individuals and athletes is mentioned as HOCM. They are often used interchangeably by authors. Okay. And this hypertrophied ventricle becomes prone for ventricular tachycardia and ventricular fibrillation. So these deaths that I mentioned are generally due to VT or VFib. Okay. Now, when it comes to its diagnosis, it may lead to obstruction, and once it leads to obstruction, I will have obstructive symptoms. That is nothing but, once there is obstruction, right, you can call it as, it is similar to aortic stenosis, right? Do you agree? In aortic stenosis, what happens? This opening is narrow, so I'm having difficulty to push the blood into the aorta. Here that opening is fine, but below that there is an obstruction. So can I call it as subaortic or subvalvular aortic stenosis? Same like AS, but the problem is below the valve, not at the level of valve. So we'll call it as subvalvular AS. It's also known as subvalvular AS if it causes HOCM. Okay. So for the diagnosis, patients who haven't yet developed HOCM, they may not be symptomatic. Once they develop HOCM, they will have the same symptoms as aortic stenosis. So then how do I diagnose? Ideally, all athletes and young individuals who are into adventure sports should be screened for this to prevent those sudden cardiac deaths. So for diagnosis, the investigation of choice is going to be echocardiography. And echocardiography is going to show some findings. So what are those findings? Number one, you will have concentric LVH. And because the left ventricular muscle mass is high, the force of contraction increases, ejection fraction increases. Ejection fraction will decrease only when HOCM develops, where I start obstructing, so I will not be able to eject sufficient. But before that, before the obstruction, only when I had little hypertrophy, I will have good ejection fraction. Ejection fraction may be increased, maybe more than 70%. Okay. Third, asymmetric septal hypertrophy, ASH or asymmetric septal hypertrophy. Okay. One more change you notice is on this interventricular septum, you will have a papillary muscle with a chordae attached to the anterior mitral leaflet. So now that this interventricular septum is more muscular, it contracts with more force, and that forceful contraction pulls this anterior mitral leaflet down during systole. Normally, the contraction force is sufficient enough to keep the leaflet in position so that it does not open in opposite direction. But now the force is increased, it pulls it down, and we will call it as systolic anterior motion of the mitral leaflet, or SAM. SAM stands for systolic anterior movement of mitral valve leaflet or anterior mitral leaflet. Movement of anterior mitral leaflet. These are important terms that teachers are looking for, that is asymmetric septal hypertrophy and systolic anterior motion. And now if you look at this ventricle, because of this asymmetric septal hypertrophy and concentric hypertrophy, the ventricle shape kind of looks like a banana, right? This looks like a banana fruit. So we will also mention it as banana shaped ventricle. Banana shaped left ventricle. So these findings help us to diagnose the case as hypertrophic cardiomyopathy. Now that we have diagnosed it, how are we going to manage? So there are two things. Number one, to prevent, because these people are at risk of sudden cardiac death due to VT and VF. To prevent VT and VFib. And second, if HOCM develops, how do I relieve the obstruction? So to prevent VT or VF, we can use beta blockers. And second, we can use implantable cardioverter defibrillators. Apart from that, in a bedside discussion, do mention, or you can here also you can write, we advise these people to avoid vigorous exertion. So vigorous extreme sports and all, because the exertion activates sympathetic nervous system that increases the chance of developing VT and VF. So they are already prone. Physical activities give that boost and VT, VF happens and they can die. So they should avoid vigorous exertion, though they should do modest exercises, not like be lazy and just lie down, because you also need to condition the heart's other chambers and muscles and your metabolic health. But vigorous exertion should be avoided. And further, if at all some vigorous exertion happens and they are prone to develop VTVA, we should give them beta blockers or ICD. If they develop HOCM, there are some pharmacological drugs available, but what is expected from an undergraduate student in the management is basically the key management, definitive management is cutting this obstructing part of the muscle. How can I cut it? Either through the surgical mode, cut this and remove. If I cut this and remove, we'll call it a septal myomectomy. From where I'm cutting? Septum. What I'm cutting? Muscle. So we'll call it a septal myomectomy. That is one choice. So if I cut this part of the muscle, the obstruction is relieved. Now the blood can easily move. So HOCM is sorted. The second option is, instead of doing this invasive surgery, I can introduce a catheter or wire into the heart and inject alcohol into this part. Alcohol causes atrophy of the cardiac muscle, and that's why you're developing dilated cardiomyopathy. Whenever you drink, your cardiac muscle starts atrophying and you will end up with dilated cardiomyopathy. So we know that from the DCM. We will use that knowledge here. Inject alcohol into this septum and it will get atrophied. Now we have even more advanced. We can induce atrophy of this with the help of laser also. We will call, when we use alcohol or laser for inducing the atrophy of the asymmetrically hypertrophied septum, we will call it as ablation, laser or alcoholic ablation. So if there is HOCM, the choices of treatment we have is septal myomectomy, that is surgically cutting the muscle, or alcoholic or laser ablation, right? So these are the choices we have. So that completes our discussion on the cardiomyopathies. So again, key points that teachers are looking for is, for the dilated cardiomyopathy, you should mention that it is left ventricle which is getting dilated. Presentation is similar to heart failure. Management is treating underlying cause and similar to heart failure. Causes wise, you should mention alcohol, titin mutation, cocaine, maybe some pharmacological drugs. Restrictive cardiomyopathy, it's all about storage disorders. One additional thing, endomyocardial fibrosis. You should mention it affects right side of the heart more. Symptom wise, mention right heart failure symptoms. Management, treating the underlying cause, cardiac transplantation. Hypertrophic cardiomyopathy, all the points that we discussed, teachers are expecting. You should mention the beta myosin heavy chain gene inherited. You need not mention the prevalence, but at least inherited mutation in beta myosin heavy chain gene, where LVH develops in the absence of increased afterload. Most common cause for sudden cardiac death in young and athletes, and it may eventually lead to left ventricular outflow tract obstruction. In that case, we call it as HOCM. Diagnosis, echo. You can also screen for the beta myosin heavy chain gene mutation, but echo is what we generally use in India. Echo findings, main thing teachers are looking for is asymmetric septal hypertrophy and systolic anterior movement of anterior mitral leaflet. Management, to prevent sudden cardiac death. Sudden cardiac death happens due to VT and VF. So to prevent sudden cardiac death due to VT and VF, we should ask them to avoid vigorous exertion, beta blockers, ICD, and if HOCM ever develops, septal myomectomy or alcoholic or laser ablation, right? So that's what I had for the part 2 of cardiology. Now, what are the other topics from cardiology? Let me mention important questions that I want you to do from the Farre notes available on the MedEd. So the first one is the systemic hypertension. It's a pretty simple pharmacology based question. Second thing I want you to do is cardiac tamponade. Third thing I want you to do is constrictive pericarditis. And the fourth thing is ischemic heart disease. So these are the major questions that we're expecting from the cardiology on the theory exam. And from the clinical corner, what are the important topics that I want you to do? I've already addressed the key questions that your teachers might ask on AS, MS, heart failure, cardiomyopathies. But of course, you need to know the approach. So I want you to do dyspnea as a symptom. Okay. Then in the dyspnea, I definitely want you to be familiar with orthopnea, PND, right? Whatever history you need to elicit. Then heart failure as a case. Then valvular heart diseases. Heart diseases. Okay. Then the other major, see, most of your major cases from cardiology are going to be valvular heart diseases or heart failure, be it right heart failure or left heart failure. Okay. Some usual discussion during bedside often spills into peripartum cardiomyopathy. You may find it in your OBG section. So if not, let me know. I will share a quick note on the Instagram and you can use that for knowing basics about the peripartum cardiomyopathy. So these are the important things that I want you to do from the clinical corner. You should know the approach to dyspnea. You should know the approach to heart failure. You should know the areas of auscultation, different types of murmurs, and the presenting symptoms of all the valvular heart diseases, and a little bit about peripartum cardiomyopathy. I forgot to mention another important thing, though unlikely to be kept as a case, because it's a bit difficult to find the cases nowadays on rheumatic fever, but often discussion spills. If it is a valvular heart disease, somehow teachers go to rheumatic fever, and it may also be a 10-mark theory question. So do cover the rheumatic fever. Okay, so that's it from me here. I'll see you in the next class. Till then, have a good time. Don't miss out on getting into the Farre section of the MedEd app and complete the remaining questions that I have shared as important. See you guys. Bye.